Hi team, we have Keenan Ford with us today. Keenan's been with Health First Group for the last 3.5 years, I think.
Yeah, August 2018, yeah.
Been one of the originals with us. So Keenan first started in Kalgoorlie and more recently over the last 6 months moved to our Albany clinic in WA. So today what we're going to talk about is when coming into a new town, or how do we start developing an NDIS caseload. So Keenan, what tips have you got for us?
Morning, Shane.
Good morning.
Yeah, first and most importantly, when a new NDIS patient comes into the clinic, the first thing that I do is I don't look at the plan, I don't look at a structure of what they've done, I just try to get to know them. And what I mean by that is, what's their strengths, what's their weaknesses, how is this person impacting this family? This person fits into a family, into a context, and if you can understand the family and the context, you can understand the patient. And from understanding that patient, your base of how many people you actually treat exponentially increases, because that family talks to another family who talks to another family, and in the disability arena, they all know each other. So technically, when someone walks in the room, I've got my client and I've got the family that I'm interviewing, and that's important. If you exclude the family, they don't get the same kind of rapport with you and they don't talk about you. So one of the things that you definitely want to do is include the family in your interview with your initial assessment with them. Okay,
and as far as time is concerned, the time is important, isn't it? So yeah. You'd be allowing at least an hour for that initial consultation?
Initial consult, minimum an hour. Of that hour, I'm spending a good 40 to 50 minutes trying to understand my patient, looking at muscle testing, looking at movements, looking at impacts, looking at behaviors that they're doing or not doing, looking at eye contacts, communication, nonverbal, everything from when they walk in my room, nonverbal to verbal, I look at and I jot it down, and I basically come up with a bit of an idea of how this little person, we can get the most out of this person in therapy in that first hour.
And do you have a specific structure that you follow?
I do. I have a very particular way of doing things. I would assess my patient and put all what I've seen into a table. That is easy reference. So when I look at my notes, I can kind of see, right, they've got low tone. This is what I want to do in my therapy. I've got my goals down on my table. The next one is what their goals are, and I've got a time frame. It needs to be something that's measurable. There needs to be a time frame to it, and there needs to be a structure that you can refer back to and say, yep, we're still on track. This is how we're going to progress to the next stage.
As far as outcome measures?
Outcome measures, I find sometimes the outcome measures are not too reliable with my autistic kids because they can't really kind of give me feedback on that. So what I'll do is use more muscle-based testing, like 6-minute up and go. And then I can use that as a standard, even though they might not be able to kind of tell me what's actually happening or where the pain is. Yeah.
So do you use that hour assessment then to determine your future bookings, and how do you go about then booking them in?
Yeah, so after that first initial maybe 40 to 50 minutes, then I'd spend the last 10 minutes of the session talking about, all right, how much funding do you have in the plan? How much of that do you want to allocate towards the physio? How frequently do you want to be seen? I could suggest it, but it all depends on their funding. Some people have very generous fundings. Some people have very limited fundings. For example, you can have one patient who's got $3,000 but only allocated $3,000 over 2 years. So you've got to space his sessions out to last 2 years. Or you can have someone with $60,000 and you can see them pretty much 3 times a week if they require it. But I would definitely say it's a conversation that you have with the family, but also bearing in mind, this is not a short-term patient. So when you book them in your mind, you've already got stage 1, stage 2, stage 3. This is going to be over the next 12 months. This is what we're going to do, and this is how we're going to get there.
So frequency of treatment, you'll tend to look at how much budget they've got.
Yeah.
But from a length of treatment, your typical go-to is about 12 months, or does that range as well?
Yes, I would do, most of the plans are a year review. They get a budget for a year, so most of my planning would be for the year. So I'd book my patients out at least 6 to 7 weeks ahead of time, and then every time they come in, I book another session in, so they're always 6 to 7 sessions ahead.
Right, okay. So you mentioned before about outcome measures. So when you progress treatment, you obviously don't want to be doing the same thing all the time.
Yeah.
I know progress can be slow quite often with NDIS clients, but how do you then determine when to progress your type of treatment or exercise-based rehab with them?
I take it down to one simple factor. What is this person's highest functional level right now, and where do they want to be? Most of the time, if we're looking at like a highest functional level of, let's say they've got back pain and they can't bend, then their highest functional level is standing without bending. If I progress it to the next phase, they need to be able to see that they can at least bend. And then once we've kind of got them bending, I would actually see, right, let's take, we'll do a little bit of a review 12 weeks in. Once I've done that review, I can see, right, we're meeting our goals, right, we're on target, and I can adjust the goals as we go. Once I see that, yep, we've met this, we've got good strength now, we've got good range, right, we've got all these boxes, we can progress it to the next phase. And then I'll have another conversation with the client saying, we're here now, where do you want to go from here? What else do you want me to do along this process so that you can actually be even better at what you want to do? And often that is a bit of a give and take kind of relationship. I find if I do a top down, me telling them what to do, it's not as effective. If you have that little conversation, right, we're here, this is what we want to do, what do you want to do, and you get their input into that, include that in the plan, it works like a charm because they came up with it.
Yes, that's a good point.
Yeah.
Now you've mentioned some very good points of what to do for NDIS clients. Have you got some suggestions of the do not do's for NDIS?
Absolutely. One of the absolute no-nos that you shouldn't do with NDIS clients is literally judge them or just treat the diagnosis. If you just treat the diagnosis, you're missing the person. If you treat the person, they fit into a context. If you treat the diagnosis does not fit into a context. If you treat any NDIS patient just according to the diagnosis, you only get so far. If you treat them according to the person, their dreams, their desires, the limits are endless. You can take them as far as their dreams will go.
Okay, good point. All right, Kenan, well, have you got anything else to add in regards to NDIS?
Yes, right from my first point, if you look at treating the family, most of our building of the base comes from the moms and the dads who are involved. And my style of therapy is I will teach not only the kid or the person, but I'll also teach the family member or the carer, because that's more important than me doing it in the session. They need to have this continuity, not just here, but at home, and the parents or the caregivers need to have the skills and confidence to be able to do it and say like, yeah, I'm doing it right. I'm helping this person. Caregiver's happy, I'm happy, patient's happy, everyone's happy. If everyone's happy, everyone talks.
Now, do you find that the caretaker will often ask you for that, or do you volunteer that and make sure that they're aware of the type of treatment that you would like them to do?
I volunteer it and I get them involved from the start. So from the first session while I'm assessing, they've been with the patient, they know the ins and outs, so they're a valuable resource in terms of getting information. They can literally be like, he doesn't like that, he likes this, she responds better to this. So they're a great wealth of information. But even better yet, if you can give them the skills to do it, they're going to tell the other carers. And I often encourage my patients to kind of film the exercise component of it, take it with them, watch it again with your carer at home. If you forget it, it's okay, there it is. So definitely I would say use the whole family, use the carers, not just the patient.
I think videoing is a fantastic idea as well, because often what we see as a physio is very different to what the caregivers or the parents can see. So if it's reinforced through a video, then it's much easier to keep them on track.
They can play it back with reference, they can always refer back to it again. If there's a new carer, then that's okay. They can also watch the video, then they're on board. If everyone's on the same page, we're all talking the same language.
All right, Kenan, well, thank you very much for your valuable advice, and we appreciate it.
Sweet.